Okay, so today we are studying about pelvic inflammatory disease or lower abdominal pain syndrome, because the pain here in this disease occurs in lower abdomen, and the organs which are involved which get inflamed are uterus, fallopian tube, um, ovaries, pelvic peritoneum. So uterus, fallopian tube, ovaries and pelvic peritoneum. And the route of spread in this is ascending infection. The microorganisms usually enter along with the sperm via the vagina, and the most common microorganisms involved are, if they ask you in general, it will be polymicrobial, and the second option goes is chlamydia. If they ask you in IUCD user, it will be actinomyces, and if they ask you in acute case, it will be Neisseria gonorrhea. And we will learn their treatment with the treatment in the following pages. Okay, moving on. And the most common age is 15 to 25 years, in which the woman is usually sexually active, and the risk factors are, as it enters usually with sperm, so the most common is intercourse with multiple partners, and the early age, or if the intercourse takes place early in the age, like before 18 years of age, that is also a risk factor. History of instrumentation, example curettage, as it can cause endometriosis, and that can also lead to pelvic inflammatory disease. So history of instrumentation, douching or washing of cervix and vagina, so the fluid used for washing is infected sometimes and or contaminated sometimes, and the bacteria enters via the cervix and vagina into the uterus and fallopian tube and ovaries and pelvic peritoneum. So it goes on. So vagina, cervix, uterus, fallopian tube, ovaries, pelvic peritoneum. So these parts are involved in PID or lower abdominal pain syndrome. Okay, so history of instrumentation in case of curettage and douching or washing of cervix and vagina, low socioeconomic class, because in that you do not care about the hygiene, and there is a increased chance of infection. The protective factors are the barrier contraceptive, which is condom. It does not allow sperms to enter in through the vagina, and along with sperms the microorganisms are also not allowed to enter. OCP use, because progesterone makes the cervical mucus very thick, and it does not allow the entry of microorganisms. The estrogenic mucus, which is watery, profuse, stretchy mucus, allows the entry of microorganisms in sperms, but the progesteronic mucus, which is thick, scanty and non-elastic. Moving on, let's talk about the characteristic of the cervical mucus in estrogenic. We learned a phenomenon known as spin bucket phenomenon, in which we could stretch the cervical mucus up to 10 cm and it won't break. In the progesteronic mucus, if you stretch it, it will break, and this is known as stack phenomenon. Okay, so in case of azoospermic partners, since sperm is not able to enter into the vagina because of its low speed, along with that microorganisms are also like azoospermic is the sperm count is less, right? So this, as the sperm is not able to enter, and so does the microorganisms. Okay, now how the sequence occurs. First, endometritis, because the first uterus is involved. It is a ascending infection, right? So first uterus is involved, then fallopian tube is involved, then ovaries are involved, and so let's talk. Uterus becomes inflamed, so endometritis, endometrium part. Fallopian tube, so endosalpingitis. Ovaries, so ophoritis. And then there leads to a formation of, because of the inflammation, fibrous bands develop around the ovaries and the fallopian tube, the femoral end of the fallopian tube, and so that is called a tubo-ovarian mass, because the tubes and the ovaries both have fibrous bands developed together. They form a tubo-ovarian mass. They're entangled with each other, they form tubo-ovarian mass, and if pus collects in them, it is known as tubo-ovarian abscess, because it kind of blocks the pathway and it leads to the formation of tubo-ovarian abscess. And finally, fallopian tube is filled with pus, because on both the sides it is blocked, the cornual end and the femoral end, and finally fallopian tube is filled with pus. It is known as pyosalpinx. And in chronic PID, hydrosalpinx form. The water collects in it, the fibrous band develops. Because we know that in all of the mucosal epithelium, the fluid is formed, right? Serous fluid is formed through mucosa, and fallopian tube is a ciliated columnar epithelium. It has a mucus layer, and there is a watery fluid in it, but it has an open pathway. But since in case of inflammation and fibrous bands forming, both the ends of the fallopian tube closes, it leads to the water being stuck inside the fallopian tube, leading to hydrospalpings. But this occurs in the chronic case. So what we know in endometritis, endosalpingitis, oophorytis, tube-ovarian mass, tube-ovarian abscess, tube-ovarian mass, then tube-ovarian abscess, right? Yeah, tube-ovarian abscess, then pyosalpinx, and then hydrosalpinx in chronic PID. So we know pyosalpinx is pus in fallopian tube. Okay, the symptoms what we will see is any of the symptoms of the inflammation. First of all, we will see the symptoms in PID is lower abdominal pain, because uterus is involved, fallopian tube is involved, ovary is involved. So we will see lower abdominal pain. Then the symptoms of inflammation, which is fever because of pus and malaise. And the diagnosis, the minimum criteria of it should be that the lower abdominal pain is unnecessary, but there should be one of the following. There should be cervical tenderness, there should be a uterine tenderness, or there should be an adnexal tenderness, or in the adnexa is the tubo-ovarian region. So there should be tenderness in the tubo-ovarian region. How do we check for cervical tenderness? We insert, like for all the tenderness, how do we check? So we do pervaginal exam, and this is done only in married female, because mostly PID occurs in married female usually, because it enters along with sperm. So this is the most common, is most commonly in the married female. So we do a pervaginal exam, and in that we insert a female in the cervix, and we push the finger, and if the pain is felt, we will say that there is a cervical tenderness, and then we push the finger towards the uterus, and if there is a pain, we say it's a uterine tenderness, and then we turn the finger towards the adnexa or the tubo-ovarian region, and if the pain is felt, we will say it is adnexal tenderness. So the diagnosis is, the minimum criteria should be along with lower abdominal pain, which is a must, because the uterus is involved, the fallopian tube is involved, the ovary is involved. So there will be lower abdominal pain plus either cervical tenderness, which can be felt on pervaginal exam when there is a pain on pushing, or uterine tenderness, or tubo-ovarian tenderness, or adnexal tenderness. Okay, and the additional criteria is, since because of the formation of pus there will be fever, so the fever should be more than 101 degrees Fahrenheit. There should be increased WBC because there is an infection. There should be increased CRP, again due to infection. There should be mucopurulent discharge, because mucus is being formed in that because of the infection and inflammation, and the lab demonstration of chlamydia or gonorrhea and discharge, because these are the most common organisms that cause that, right? Gonorrhea, Neisseria gonorrhea, we said in acute infection, and chlamydia, if other than polymicrobial, if the question asked, we say it is caused by chlamydia. So the additional criteria is temperature should be greater than 101 degrees F, increased WBCs, CRPs, and there should be mucopurulent discharge, and there should be a lab demonstration of chlamydia or Neisseria gonorrhea in the discharge. Definitive criteria is endometrial biopsy. Okay, so that was for the diagnosis. This was the minimum criteria, and then you can do additional criteria. But the definitive criteria, which gives a thumb up on, like, it's a stamp that it is a PID. So what do? We do endometrial biopsy, and we say that if there is an endometritis, this is inflammation of endometrium. Endometritis, inflammation of endometrium, which usually occurs, right? And then on ultrasound, we can also give a definitive criteria by ultrasound when we see there is a tubo-ovarian mass or adnexal mass. But the gold standard, which is the most conclusive. It says that if there is a trickling of pus via femoral end of fallopian tube, it confirms PID. Otherwise, pus in peritoneal cavity in general can be due to various reasons, right? But if the pus is trickling from the febrile end of fallopian tube, it is a conclusive of PID. Femoral end of fallopian tube. So laparoscopy is the gold standard, but definitive criteria which we usually do is ultrasound and endometrial biopsy. Now, syndromic management. We do a syndromic management because if PID left for too long, it can become chronic and it can cause various problems. So when the patient comes and we see the minimum criteria after checking, and so we do a syndromic management. There are two kits, yellow kit and gray kit. Yellow kit is kit number 6 and gray kit is kit number 2. In yellow kit, we give them we give them in general for if there is any of the bacteria, so all of these bacteria will be killed. We give metronidazole 400 mg BD. Metronidazole 400 mg BD, and metronidazole is given for various anaerobic infections, because we already said that most common cause of PID is polymicrobial. So for anaerobic infections, we give them metronidazole 400 mg BD, and this we give for 14 days. Remember, in vaginitis it was for 7 days, but in case of PID it is for 14 days. And we give them doxycycline, which is 100 mg BD. This doxycycline we give them for chlamydia, and this is given 100 mg BD for 14 days or 2 weeks. And then we give them tab cefixime. This is for Neisseria gonorrhea, and we said Neisseria gonorrhea causes acute infection, so this is not given for 14 days or 2 weeks. This is given 400 mg stat 1 times a day. For male partner is also treated because to prevent reinfection. Even if the male is asymptomatic, we still treat the male patient with the gray kit, which is kit number 1. Sorry, I mistakenly said that kit number 2. So it's kit number 1, and we give them metronidazole. We give them cefixime, which is 400 mg stat, and also we give them azithromycin, which is 1 gram stat. So azithromycin is for chlamydia and cefixime is for gonorrhea. So both doxycycline and azithromycin is for chlamydia. Doxycycline we give 100 mg BD, and azithromycin we give 1 gram stat. Okay, now in chronic PID, fibrous bands develop, and what does this fibrous band do? The symptoms are there is restricting pain on movements due to fibrous bands, due to frozen pelvis, because the pelvis is a fibrous band. So there's a pain in right hypochondrium, because the fibrous bands are so numerous that they reach up to the liver, and they cause pain in the right hypochondrium where the liver is present. And it occurs due to stretching of the perihepatic adhesions, and this is known as the Fitz-Hugh-Curtis syndrome. So if you have pain due to fibrous band in the perihepatic region, in the right hypochondrium due to perihepatic adhesions, this syndrome is known as Fitz-Hugh-Curtis syndrome. Okay, what's known as Fitz-Hugh-Curtis syndrome, and this is due to perihepatic adhesions, pain in right hypochondrium region. Alright, yeah. So a lady presents with lower abdominal pain 2 years back, and she was treated with yellow kit. Now she presents with restricting pain on movements, likely diagnosis chronic PID, because even if there is not pain in right hypochondrium, overall chronic PID causes restricting pain due to presence of fibrous bands. So, and it is known as frozen pelvis with fibrous bands, frozen pelvis. This frozen pelvis, right? The complications, most common complication is infertility, and if the tube is partially blocked, it will be ectopic pregnancy, completely blocked infertility. Investigations: first we do ultrasonogram. In ultrasonogram we see bead on string sign, we see waist sign. I'll explain you. Okay, so bead on string sign, because when fibrous bands begin to develop, they appear like a little small dots on ultrasound and are known as bead on string sign. Okay, they're small dots. So in a string, when we put our beads, it appears as a dot if we see from the upper part. So yeah, it will be beads on a string sign and are known, and these are longitudinal sectional tube and appears linear. If ultrasound probe is rotated over the fallopian tube is visualized circular because the tube is circular, obviously. Then we see waist sign. So when these fibrous bands are developing, they pull the fallopian tube inside. Okay, they pull it inside and causing the narrowing of the fallopian tube at a point, and this is known as waist sign because our waist is snatched. The waist of a woman is snatched inside. So yeah, it causes a waist sign. So when fibrous bands are pulling the fallopian tube inside. Then we have cogwheel sign. When the fibrous bands become large, they appear as a spoke of wheel, and this is known as cogwheel sign. And then in chronic PID we see hydrosalpinx because the fallopian tube is blocked at both the ends, so the fluid gets accumulated inside. So first we see beads on a string sign because when the fibrous bands are developing, they appear as a small dots. Then we see a waist sign because the fibrous bands are pulling the fallopian tube inside, it gets snapped, it appears as a waist. And then we see cogwheel sign. When fibrous bands develop, they appear as a cogwheel, as a spoke of a wheel. And then we see hydrosalpinx in chronic PID. There will be water filled because the both ends of the fallopian tube are closed. And in laparoscopy we see violin string sign. Okay, so this is the fibrous bands. In laparoscopy we see it appears as a strings of violin, so it is known as violin string sign. Okay, now most common site of tubal block due to chlamydia and gonorrhea is femoral end block. And most common site of tubal block due to TB is coronal block. Okay, we are further going to learn about tuberculosis. In tuberculosis, the most common site which is blocked is corneal end because the TB comes from descending infection and then it moves towards the endometrium. Rarely it moves towards the ovaries, and so it can affect the femoral end as well, but usually it moves towards the endometrium. So the most common site of the fallopian tube which appears blocked is corneal end. But in case of PID, it is an ascending infection and it moves towards the ovaries and it usually blocks the femoral end. You can also, as it was confirmed that when you see dripping of the pus from the femoral end, it is a confirmatory for PID, right? We already learned here that and that also in laparoscopy. In laparoscopy, the gold standard was trickling of pus from the femoral end of FT. So the most common site for the block in case of chlamydia and gonorrhea, which causes PID. Chlamydia, what does it cause? Generally. And gonorrhea, Neisseria gonorrhea, acute PID. And what was causing IUCD? Was it actinomyces? No. What was it? I forgot. Yeah, actinomyces. In IUCD, the most common microorganism is actinomyces. So overall, now we're talking about Neisseria gonorrhea and chlamydia. It blocks the femoral end, from where the trickling of pus can be seen in case of laparoscopy. So in laparoscopy, we see fibrous bands in the form of violin string sign. So that's it for PID.